Hey everyone, and welcome. If you're a medical trainee, you have definitely been in this situation. A patient mentions some fuzzy memory, or maybe a worried family member pulls you aside after an appointment. It can feel a little overwhelming. So today, we're going to break down a really practical clinical approach to cognitive impairment. The goal is to give you a clear framework so you can assess, diagnose, and manage these patients with a lot more confidence.
All right, so here's our game plan. First, we'll talk about how to spot those really subtle signs of impairment. Then, and this is a big one, we'll tackle the crucial step of figuring out if this is acute delirium or a more chronic decline. From there, we'll walk through the essential workup, decode some common dementia syndromes using classic imaging, and then we'll wrap it all up with actionable management steps you can start using right away. Okay, let's dive right in with section 1, spotting the impairment. Now, the key thing to remember here is that the first signs are often behavioral. It's usually not a patient coming in saying, "I think I have memory loss." You really have to put on your detective hat for this one.
So let's start with a scenario you've probably already seen. Your patient's missed a few appointments, and when they finally come in, their family member is doing all the talking. This isn't just a scheduling mix-up, it's a huge diagnostic clue. In a situation just like this, your suspicion for an underlying cognitive issue should be way, way up. And those clues lead us right here, to these clinical red flags. You've got to be on the lookout for things like a family member pulling you aside to say they're concerned, or seeing changes in medication adherence, or maybe a patient who always came alone now can't seem to manage an appointment with their partner. These are absolutely critical signals that should make you think, okay, I need to do a cognitive evaluation. All right, section 2, acute versus chronic. So once you suspect there's a cognitive issue, you hit this massive fork in the road. Is this an acute change, something that just happened, or is this a slow, chronic decline? Figuring this out is everything, because your entire workup completely depends on the answer.
This table just lays out the core differences perfectly. Look, delirium hits fast, it's acute. Its course is all over the place, up and down. And the classic feature, it messes with attention. Dementia, on the other hand, is insidious. It kind of creeps in slowly, progresses steadily, and attention is often totally fine in the early stages. Getting this distinction right is just fundamental.
So let's be crystal clear. Delirium is a medical emergency. It's a huge sign of some underlying brain dysfunction, maybe from an infection, a metabolic problem, or a medication side effect. Your job isn't to treat the confusion itself. It's to find and reverse the underlying cause, and you got to do it fast. On to section 3, the initial workup. So you've pretty much ruled out delirium, and now you're thinking this is a chronic cognitive decline. So what's next? Well, this is where we start building our diagnostic foundation with a really systematic workup.
The American Academy of Neurology gives us a really clear, easy-to-follow checklist for this minimum evaluation. It's got the basics: a good exam and cognitive screen, a look into things that can mimic dementia like depression or sleep apnea, a super detailed medication review, and then some key labs and imaging. The whole goal here is to systematically rule out any reversible causes before you even think about landing on a diagnosis of an irreversible dementia. And here is a clinical pearl that you just cannot overstate. Your patient might have zero insight into their own problems. A spouse, a child, a caregiver, they are often your absolute best source of history. Their perspective on the timeline of symptoms and how it's actually impacting the patient's life is just invaluable. Okay, section 4, decoding dementias. Now for the really cool part. We're going to do a rapid-fire visual tour of the most common dementia syndromes. The goal here is to build some really strong illness scripts in your head by linking the clinical picture you see in the office directly to the imaging. First up, the big one, the most common cause of dementia, Alzheimer's disease. The classic story is that insidious worsening of short-term memory. And this MRI, it shows us exactly why. Look at that volume loss in the hippocampi. Those are the brain's memory centers. The anatomy just perfectly explains the main symptom.
Next is frontotemporal dementia, or FTD. Now with this one, the first sign isn't memory loss. It's a really dramatic change in personality, judgment, and behavior. And again, the scan tells the whole story. Look at that profound atrophy just wiping out the frontal lobes, the very seat of our personality and executive function. It's an absolutely striking correlation. And this brings us to a really key diagnostic pearl for FTD. You might have a patient whose family is describing major problems at home or at work, but then you do a cognitive screen in the office and they do surprisingly well. This mismatch, this disconnect between their real-world function and their test performance, that should scream FTD.
This table is a fantastic way to kind of summarize the key differences. So with Alzheimer's, it's mostly memory loss early on. With dementia with Lewy bodies, you get that early Parkinsonism and those vivid visual hallucinations. And like we just saw, FTD is just dominated by those early, really profound behavioral changes like disinhibition.
Okay, now this is a must-know, critical patient safety point. I cannot emphasize this enough. If you even suspect dementia with Lewy bodies, you have to be so careful with antipsychotic medications. Giving a standard dose of a neuroleptic can cause a catastrophic, horrible reaction. This is one of the biggest reasons why making an accurate diagnosis is so incredibly important. Let's talk about a don't miss diagnosis, normal pressure hydrocephalus, or NPH. Why is it a don't miss? Because this is a potentially treatable cause of dementia. The key feature is often a really obvious gait problem, and the hallmark on imaging, as you can see right here, is these huge, enlarged ventricles that seem way out of proportion to the amount of brain atrophy.
And this brings us to that classic triad you probably learned: wet, wobbly, and wacky. The gait is often the first and most pronounced symptom, that shuffling, magnetic gait where it looks like their feet are just stuck to the floor. Then comes the urinary incontinence, and then finally the cognitive impairment. And finally, we have vascular cognitive impairment. This is what happens when cerebrovascular disease, things like mini strokes, damages the brain over time. Your big clue is a patient with a heavy burden of vascular risk factors: hypertension, diabetes, smoking. And the MRI will often show these diffuse white matter changes, which basically represents widespread damage from all those tiny insults. All right, last section, management and takeaways. We've spotted the signs, we've ruled out delirium, and we've worked through the differential. So let's finish with what we can actually do for our patients. This is all about actionable advice you can start using today in clinic. This list from the Lancet Commission is so empowering. It shows us that a huge chunk of dementia risk is actually modifiable. As clinicians, we can make a real difference by helping our patients manage their blood pressure, treat their hearing loss, stay physically active, and maintain their social connections. This is huge. And look, if you remember only one single thing from this section, please make it this. According to all the data, the single most effective thing we can do to help prevent cognitive decline is regular physical exercise. It's simple, it's evidence-based, and it is a powerful message you can share with every single one of your patients. Now, when behavioral symptoms do start to develop, the guiding principle has to be starting with non-drug approaches. Before you even think about reaching for that prescription pad, think about environmental changes, establishing routines, behavioral strategies. Those should always be your first line of attack. So we'll end with this question to take with you into your next clinic. After everything we've covered today, from subtle red flags all the way to complex diagnoses, what's that one single most important thing you can talk about with your patients? Well, it often comes back to the basics, doesn't it? Like exercise. And that is a really high-impact conversation you can have today. Thanks for joining me.